it was a very well presented paper and the critical analysis. And I think quite a lot of important points have already been covered in the discussion, in the presentation, and in the critical analysis. Um, I think the selection of paper, I would really say, is really good because the most important thing is what is clinically applicable in our setup on a day-to-day basis. And as most of our setups are performing AV fistula surgery regularly, and maturation of AV fistula is an important question that has to be raised. So discussion about this is extremely important. Clinically, how things are happening, I think that is the main thing that we should be looking at from our own point of view, and then seeing where the application of this paper comes in. So if I look at my practice, clinically, do I look at every patient to apply rule of six? No, that is not possible because every patient to be sent for a scan adds to the cost. And there are a lot of patients who, if clinically it feels that their fistula is mature, we start using the fistula. The important point about the patients coming from other areas and then getting dialysis in other areas means that the follow-up that we have of our patients is very, very low. There are patients who may, I think if I say my follow-up protocol is that I want to see the patient between 7 to 10 days after the fistula formation, and then at about 6 weeks time in order to assess whether the fistula is ready to be used. And these are both clinical assessments. Most of the patients do turn up for the 7 to 10 day follow-up, but the number of patients coming for the 6-week follow-up is not very great. But as I've said, most of the patients we do assessment clinically, and if clinically it feels that the fistula is ready to be used, then it starts getting used. It's the patients where we feel that the vein may not be mature, the thrill isn't very good, or the vein feels deep. In those patients, I get a scan done, and then I look at this rule of six criteria. And as it has been mentioned in the paper, the most important point that I look at is the flow rate. If the flow rate is good, then there is, even if at 6 weeks the vein hasn't matured enough, then I think given some more time, there is hope that fistula will mature without any secondary intervention. So that's the protocol that I'm using because doing a scan in every patient obviously adds to the cost. There was one more thing which Dr. Zia mentioned in the 3 things he was asking. I don't remember, but these are the points of discussion that I wanted to raise as well from other centers. That what are the protocols that they are following.
These are very excellent and very relevant comments, and I like that. Most of in our setup, patients are last to follow up. We cannot actually know how much fistulas are actually mature. And second is it is the clinical assessment, but very important that the flow rate makes the difference whether the fistula is going to have a good 2-needle dialysis or not. I'm just wondering, which I see in this article, that most of the fistula are made from the brachial artery, either the brachiocephalic or the brachiobasalic fistulas, and there are proportion of the radiocephalic fistulas are low. Although this is their first preference, half of the patients are diabetic, and I'm just wondering for that. And then there is Dr. Ammar Pirzada. Dr. Ammar. Dr. Umar, or then Dr. Ammar.
Sorry, yeah, that was the point which I had forgotten, which I also wanted to focus on. With time, obviously, I think, and with experience, you do change things. Initially, when I started my practice, and my preference was to go for distal first technique in making a fistula. So the first fistula I would want is a radiocephalic in most of my patients. But I think with experience and especially looking at the amount of patients that have diabetes in our country, I have moved on to avoiding radiocephalic AV fistula in patients where the pre-op ultrasound has shown calcification in the distal vessels, where the age, the gender is usually female, and the age is above 65. So in elderly patients, I do prefer to go primarily for an elbow fistula rather than going for wrist fistula, because the chances of having a good fistula with a mature outcome is planning my fistulas.
That state means in diabetic patient maybe the first preference due to distal disease, maybe the brachiocephalic as compared to radiocephalic. That is great point to know. G. Amar, you want to ask any question? G.
So my question is to Dr. Omar. Sir, I'm Dr. Omar, currently working as a year two fellow. So probably as a beginner, my question may sound very childish, but it is just intriguing me. So sir, you mentioned that we decide about maturity on the basis of clinical examination. So sir, the rule of six or the other criteria that I've mentioned everywhere in the literature, obviously it talks about objective, and we in our setting we need to be smart enough to understand the limitations of our working environment in terms of cost effectiveness and all. So sir, on the basis of clinical examination, I think probably just based on the palpation of the vein and the flow in terms of thrill, would there be anything else that we can look for in our clinical examination, or it's just the two things, whether we can palpate the vein and we can palpate the thrill? If these things are present, the fistula should be good enough to go, or is there anything else you look forward to?
So, Amar, actually, in my clinical practice, I go for the three things when I am going to be making a fistula. I want a vein which is more superficial. It has length in which two needles can be cannulated, and it should be superficial and enough that easy cannulation can be done. And the flow when fistula, that is the thing when I am planning my access. So I see that is this vein is going to be straight one, and when it is going to mature, it has enough length where two needles can be cannulated, and is it going to be superficial enough or not? If it is not superficial, I plan whether I have to superficialize at a one stage or at a two-stage method. And then third thing is I try to make the fistula which have a artery which is healthy, not calcified, because the whole idea of maturation is that there is going to be arterial dilatation, which is going to increase the blood flow. But if the vessel has calcification maximum, there is less chances of its getting dilatation and getting mature. So I want a healthy artery and a healthy vein, which is going to be made, and that is going to increase the flow. These are the three things I am looking for a fistula to mature, or when I am planning for an access to be created. And then the general principles that I always prefer in non-dominant hand, I prefer a distal than the proximal. Upper arm is always preferred than the lower extremities. Yeah.
Thank you so much, sir.
Yeah.
Thank you for the insight, sir.
I will actually like to listen the views of others and any challenges they find in access creation or any maturation. What are the common causes of non-maturation in this fistula? So we have a question from Dr. Ghulam Ali. That is, what is the role of antiplatelets in the nature? Ghulam Ali, you can verbalize your question, please? We have a hand raised by Dr. Wakas. Dr. Wakas.
Well, first, I would like to respond to this question. As far as the role of antiplatelets, especially Loprin, is concerned, there used to be a time that they used to give Loprin pre-operatively. But according to the guidelines of European Society of Vascular Surgery, there is no role of pre-operative Loprin in these patients, but post-operatively, definitively, the early failure due to thrombosis that can be avoided. That has been proved statistically that Loprin is effective. So there is no role of preoperative Loprin in these patients, but postoperatively, definitively, the Loprin has been studied. Clopidogrel has not been studied as such, but Loprin definitively has got a role. Secondly, I joined a little late because of power failure here in Islamabad. So I think I missed a very fruitful discussion. But I would just like to add a few things as far as this article was concerned. Uh, uh, I think, although that was not the scope or the probably the purpose of the authors, but preoperative assessment as far as the diameter of the vessels is concerned, that has definitively got an effect in the overall maturation of the fistula. If we read the literature, the caliber of the veins should be around at least 2.5 millimeter at wrist, and it should be around 3 to 3.5 millimeter at the elbow, as well as the caliber of the vessel, the arteries, that should also be, radial artery should be at least 2.5, and the brachial artery should at least be 3 to 3.5 millimeter. Although they have mentioned that in postoperative, when they assessed fistula for maturation, the caliber of the artery was found to have least effect on the overall functional maturation of the fistula. But preoperatively, I think the assessment of caliber is internal diameter of the vessel is very important, and that is to be done through venous mapping and not by simply by clinical examination. And as far as the diabetics are concerned, as Umar was talking, usually the wrist fistulas, they do not perform very well in diabetics as well as in female patients. But in my own personal experience, I have seen certain diabetic patients who have got, very good caliber of the radial artery. Although the artery has not, it is atherosclerosis, but has not reached to the stage that it has developed calcification. But due to positive remodeling, sometimes you get a very good artery that is, of a good caliber, and the fistula can easily be constructed. And such fistulas, in my experience, they do very well in the long run.
Thank you for your valuable comments. I appreciate that you have rightly said that preoperative assessment makes the difference, especially the caliber. And I understand that the caliber of arterial diameter, you are talking about the internal diameter of the artery, means sometimes the vessels are atherosclerotic. We are very much concerned with the internal diameter, that it should be at least 2 to 2.5 mm. And we have about 5 minutes before we close this session. If there's any comments from any session or any questions, they are most welcome. Otherwise, we can say that we can close.
Sir, can I ask one question, sir? Sir, is the ultrasound mapping is necessary in any patient that is undergoing for dialysis for AVF formation?
Yeah.
Preoperatively, is the ultrasound is necessary for mapping of AVF?
Yeah. Anyone wants to comment on this? So it is nice to go through the DOKI guidelines. DOKI guidelines in 2000, when there was 2006, and then they are 2018. These are very good guidelines. Although there is no randomized controlled trials which are actually evaluating the efficacy of the preoperative ultrasound versus the clinical examination, but preoperative ultrasound do make a difference. And they have actually mentioned very good that it is just like diagnosing pneumonia on bronchi on clinical examination versus doing a chest X-ray. So chest X-ray is going to be specific, and there is not going to be any study auscultation of the bronchi versus a chest X-ray. So although the evidence may not be there, but we see in clinical practice that ultrasound do makes a huge difference. They are eyes of a vascular surgeon. They give the caliber of the vessel. They give whether the vessel is going to be stenotic or not, and about the vein, diameter of the vein. After tourniquet, they are going to dilate or not. Is there any thrombosis? Is there any venipuncture? Or what is the caliber of that? and it is super method of assessing, and especially in the post-operative period where you have mentioned in one of the articles, they have assessed that at 1 week when the flow is more than about 600 ml, these fistulas are going to be matured for, and then for the maturity of this fistula. So I saw this is necessary part of our examination unless there are very good arteries and veins which are there. Yeah.
Thank you, sir.
So this is one of the sessions we have started from, and we are going to rotate these sessions in different institutes. And I see Dr. Bakwas hand up. Dr. Bakwas, you want to add something?
Yeah, I just wanted to add, I don't know whether you have discussed this point or not, but as mentioned in this particular article, the role of BMI and the depth of the vein. Now, one of the solutions, I don't know what they have studied, to what extent they have digged this fact, but one of the studies I read a few weeks back, they suggested the role of liposuction and brachioplasty instead of superficializing the vein. Liposuction has been found to be very effective, especially in those obese patients in whom the cephalic vein is quite deep, and superficialization leads to another surgical procedure. So relatively a simple procedure like liposuction can help remove the excess fat and reduce the fat in that particular area.
Thank you, because that is very important point that vein has to be superficialized, and there are different methods. But in this particular article, there are very two interesting points which has been raised out. Number one, they have actually pointed that BMI is directly related to the vein depth, and then they say that the vein depth does not correlate. That is which is very interesting. Vein depth does not correlate with the maturity of the fistula, but BMI is associated with poor actually maturation. So although they have relationship, and they have found that the vein diameter and the vein flow is more important than the vein depth. But definitely for cannulation and ease of cannulation, superficial vein is much more easier to cannulate as compared to, and is necessary, I think so, as compared to a deep veins in which the needles may be lost. Then we have a very question from entertainment. What is the role of balloon-assisted maturation in autologous fistula? Any comments from that? So, can you mention who is asking, and can someone speak up? What is the question, and just introduce and then ask the question. Entertainment A03 names, yeah. So balloon-assisted maturation do improve the maturation rate of the fistula, especially the long balloons, and there have been studies which have proven their efficacies, especially the fistula which are now maturing after 4 weeks. They have started using balloons and doing repeated intervention, and that helped to improve the maturation rate. And they have role in the maturation of these fistulas. So with that, I actually close this session. We are planning to do this journal club every month, and we wanted all institutes to participate for that. And I will circulate a Google form so that for the particular month, the institutes can give their preference, and that will remain the pattern like this, that will select one of the articles which will be presented with the fellow and will be supervised by faculty. And one other activity we wanted to start is the lecture by a faculty. For that, I am working for that. And once a month, we'll be doing this, and we will try to actually again rotated different institutes, that different institutes actually share their experience and their understanding about distant diseases and pattern of that. And with that, I thank you everyone, especially who have participated this and came from their precious time, especially Dr. Iqbal Khan. I see Dr. Khalil Ahmed, Dr. Fahd, Dr. Fazal, and Dr. Farid Sheikh, and definitely Dr. Waqas and Dr. Umar Ehsan. And thank you, Shoaib and Dr. Ammar, for presenting. Thank you for that.
That's all. Thank you, sir.
Thank you, sir.
Thank you, sir.